about critiquing a research paper, what we need to know. So let's go through one scenario, which is a 45 years old lady presented with acute abdominal sepsis, and she was resuscitated by using sepsis 6 protocol. On investigation, she had increased inflammatory markers, picture of obstructive jaundice on LFTs, and once we got a MRCP, she had a CBD dilatation. Her serum amylase was over 1,000. On day 3 of admission, she got ERCP done, and her CBD was cleared. On day 5, she underwent a laparoscopic cholecystectomy. Her postoperative course was excellent, and she was discharged on day 8 with an advice to GP to monitor her HbA1c level on 6 monthly basis and to do her bone scan every 2 years. So, what were the critical steps in the management of this patient? There are quite a few, and this slide shows that this patient was managed successfully because the doctor involved in the care knew about the sepsis 6 protocol, had enough knowledge and skills to start this protocol. Number one, we had institutional support to get MRCP done within a couple of days, and we had a gastroenterologist colleagues who did an ERCP. Surgeons did a laparoscopic cholecystectomy, and on discharge, the F1, he was smart enough to follow the NICE guidelines for the patients who have a pancreatitis, and he actually advised GP to monitor HbA1c levels on 6 monthly basis and get a bone scan done on 2 years. There are quite a few things which have been done for this patient. What was the aim of this management? And I think everybody would agree the aim was to improve the patient outcomes. And this is the center for the institution, the improving patient outcome, and also for the professional bodies who monitor individual person's practice. So I'm talking about GMC, I'm talking about NHS. So both of these bodies, they actually stress a lot on the improving patient outcomes. So talking about the NHS values, so among the 6 values, one is commitment to quality of care. So if we go into details, so this is such an important issue that we have a system in place called clinical governance. So this system ensures that the care patient receive, that is of optimum and as of a high standard. And to ensure this, what we do clinical audits, we do education training, and we also measure the effectiveness what we are doing, which is called as clinical effectiveness. And if we talk about the GMC, the 2 domains which are interlinked with the quality of care are improving your knowledge and skills and performance, and safety and quality again. So if we put everything together, then it comes the common theme of all these strategies is actually ensuring quality of care by providing evidence-based medicine. Now, what is evidence-based medicine? So evidence-based medicine is a systematic approach to clinical problem solving by the integration of best research evidence combined with the clinical expertise and patient values. So the components are 3: best research evidence, clinical expertise, and patient values. And this was first defined in 1996, so we are about 15 to 20 years down the line with this evidence-based practice. Now, we are saying that one of the component is actually best research evidence, which means that we may have an evidence which is not actually the best. So we have to actually identify the best evidence. There is already a few criticism regarding the research we are getting on everyday basis. A lot of research is coming from the business industry, so they have their own business interests. So there may be a bias from the business partners, from the industry partners of healthcare. The volume of evidence we are getting, especially the clinical guidelines, that has become really unmanageable. So you are getting hundreds and thousands of papers on almost monthly basis. Then we need to be aware that statistically significant benefits do not translate to the benefits, statistically significant benefits in clinical practice. So we need to really differentiate between these 2 concepts. A lot of time we are actually using algorithms and technology. Like recently, we have done a meta-analysis for artificial intelligence-based models for guiding the endoscopy uh, for taking biopsies for the patient with Barrett's esophagus. Now, most of the time, these algorithms, they are actually driven by the complex systems rather than they are being patient-centered. So you may not sometimes get actually a patient benefit by these algorithms. And on top of that, sometimes they do not consider the complex multimorbidity among the patients. So every patient should be dealt on case-by-case basis. So we know that the practice is guided by the research, but sometimes practice may be misguided by the research. So there comes a role for critiquing a research, any type of research. It could be a research paper or anything, any piece of evidence. This is such an important thing that entry to the training requires that you should pass a station on ST3 interviews where you have to critique a paper and a piece of an abstract. And during the 5 or 6 years of training, you are trained by running the journal clubs and by doing the further training. But as an FRCS candidate, you have to critique 2 papers. One is in general surgery and second is of the special interest. And you're given about an hour to do so. So once you have critiqued a paper, there could be a few outcomes. One is that that paper is not of any interest and you're going to bin it. Or it could be of a very good standard, which is going to change your practice. In between the two could be developing your own research based on the evidence you have received from that paper, or you could wait for the further evidence so that the evidence evolves over a period of time and then you change your practice based on that. But these are the few of the outcomes which result from critical appraisal. So it means that you need to develop skills for the critical appraisal, and these are by attending courses and by running regular journal clubs. And I would thank the organizers because journal clubs are regularly run by the team, I think once a monthly basis. So we are not running a workshop today. I'm just going to introduce a bit of an idea that how should we critique a paper in a systematic way. So what we need to do is that what is hierarchy of research evidence. So what is the best evidence and what is the poor evidence. And then what are the methods of critical appraisal? What is the role of alignment? I want really to learn this word. What is alignment here? So at the end, we'll have how to report critical appraisal and we'll summarize at the end. So it will take about 20 minutes for this. So what is the hierarchy of research evidence? All of us, we start somewhere with a case report. So this pyramid, on the base, you can see ideas, editorials, and opinions, but I think these are more of the experts who do these things, like the consultants and who are experts at the field, they write. But actually, on the, contrary to the expectations, these opinions, they do not count a lot in the evidence. So we start with the case report. Some of us write the case reviews, the case series with the literature review. Then the middle part is actually the case control studies and cohort studies. And I think surgical practice, we do a lot of these things, case control studies and cohort. Case control studies is where you already have different outcomes and you go a retrospect and then see what did well and what didn't do well. While in the cohort studies, you take the 2 different groups and follow them up over a period of months or years and then see what were the outcomes to differentiate what did well. I think the gold standard is actually a randomized control trial where you have the people recruited to the 2 different groups on randomized one, and then you do give intervention to one and not to the other one, or give one intervention to one and the second to the other one, and then compare them after a period of time. That is called as a gold standard. And then if you have a lot of randomized control trials from the different centers, then you combine all of them together to get a meta-analysis. So systematic review and meta-analysis, they form usually the basis for the guidelines developed by different sources. We always love to put numbers on these things. So the Oxford Center of Evidence-Based Medicine has actually graded this hierarchy. And based on that, you can have the best evidence, which is the systematic review of randomized control trials, which is level 1A evidence. So randomized control trials are level 1 evidence, maybe A, B, C. Then we have a cohort studies, which are level 2 evidence. It could be a single cohort study, or it could be a systematic review of that. So that is level 2. And then we have a level 3 evidence, which is case control studies and their systematic reviews. Case series is 4 and expert opinions are 5. Now, steps of critical appraisal. So how should we start appraising a paper? I think first of all, we should make a sense of the title. Look into the terminology used. It should not be too wordy, and it should make sense on the first instance, and the topic of the topic has been described should be of recent interest. Then you need to see whether this is of a specialist interest or is a general interest. Some papers, they might not be, you may not be the suitable audience for that. Then assessing the credibility. So there are quite a few things which can actually make a credible paper. So one is that the article is higher on the hierarchy. Number one, like it's a randomized control trial, or at least a cohort study, and the paper coming from a good institute and some renowned authors. It has been published in a good journal with a good impact factor. Look at the publication date. It should not be an old paper coming about 20 years ago. Look at the funding sources, because if the industry is involved, then you need to be a bit skeptical about that. Have a look on the references. These should be recent and balanced, and it should be published. The references should be coming from the articles published in good journals, and they should not be coming from the website information. Now, what is impact factor? So impact factor is actually a guide towards the importance of a journal in the research area. So if you want to measure, it's actually a citation to publication ratio. So if you have 200 papers published in 2 years time, and you have 400 citations for this period, so in 2021, then the impact factor will be 2. It's not really a very good measure of importance or the impact, but it is used very frequently. To give an example, we have about 500 journals in surgery, and the top 5 journals are listed here. These include Annals of Surgery and JAMA Surgery. And I think they missed the BJS, which has impact factor of 5. So out of these 500 journals, the only 46 journals, they have an impact factor 1 or above. So the citation to publication ratio 1 is only for few journals. So once you have assessed the credibility and you are happy that this is from a credible source, then you start reading the abstract. Now it should give you a general idea that what the problem is and what were the objectives and how the methods were run, and then what was the conclusion. You have read the abstract, but then you should actually see, after reading the whole paper, whether this abstract is in itself authentic or not, because it may not be a true representative of the actual article. So next job would be going through the whole article. So let's take an example. So you have an RCT published in June 2020, which is coming up like this month, in Annals of Surgery, which impact factor is 4, by the authors from School of Medicine from Japan. And it encourages that there is no difference actually between the single incision for colectomy or for the colon cancer versus the multiple incisions, because the oncological outcomes are not different. So it's a good journal coming from a renowned or good center, published in a good journal. It's a randomized control trial. So would you change your practice based on this information? Probably not, because there's a lot of other things to be done. So credibility does not translate actually into the validity and reliability. So next our job is to assess the validity and reliability of this study, of the paper, by reading the whole paper. So what is a validity? So validity means that they are claiming something, and that is actually a true representative of the reality. Like the absolute weight is not a true representative of obesity. While BMI may be a true representative. So if they are trying to measure something, have they actually measured the reality or not? It is away from the reality, because there is only one reality. You can't have multiple realities. The reliability means that if you run this study again and again in a different circumstances over a different centers, then it will produce the same results. Then it means these results are reliable. So validity and reliability are the two things which we need to assess while reading the paper. So a valid and reliable study will have an alignment. What do I mean by alignment? So alignment means that the problem, after the review of literature, they have identified a problem, and this problem has been introduced in the introduction part as a problem. Now, aim of the study should be to provide a solution to that problem, and the objectives are actually a measurable, statements of the aim itself. So these objectives should be reflective of the aim. So everything is getting linked. So you have a problem, you want to find a solution, and you have developed objective to find that solution. Then you have designed a study by which you want to measure the objectives, and that study design should be an appropriate design. Now the participants which you include in the study, they should be a true representative of the population where you are going to apply the result. So if you are measuring some outcome in the diabetic patients, then you should include in the study the diabetic patients only, because they will represent the true population of diabetic patients. There should be no introduction of bias at any point. And what I mean by bias is there are a lot of sources of bias. It can be from the investigator, where he has designed a study poorly, could be a systematic error or non-systematic error. Then you have a participants which may have a different types of biases because of the recall issue or because they are not the true representative. Then the one who is running the statistical test, that may be biased intentionally or non-intentionally. Then the literature you review and present in the discussion part, that may be biased, and you may miss some publications which are important, and you are not presenting a balanced view. The instruments used to measure some thing, that instruments are actually not the valid and reliable, so you can have a bias because of them. So there could be a lot of other variables as well. So the instrument of the data collection, they should be valid instruments. And just for an example, to measure the patient satisfaction in the hospital, somebody has done a systematic review. They have identified about 1157 records on that, and through this they identified there are 26 different instruments to measure the patient satisfaction in the hospital. So among these 26, they all of them will not be reliable and valid instruments. So we need to really look into what has been used to collect data. Then comes the statistical methods. So these methods should be aligned with the study design and objectives. So you must have a good knowledge about the different statistical tests, because you cannot compare frequency by doing a t-test, or you cannot compare the averages by doing a chi-square test. So you need to have a very good knowledge about these different tests. Then there should be no errors while you are presenting the results, or errors might have been introduced during all this process. So there are two types of error which are more important. One is type 1 error and type 2 error. So you suppose you have reality. You say that there is no difference between treatment 1 and treatment 2, and this is the reality. If you find this reality, that's good enough. But if it goes against the reality, there is no difference, but you find a difference, then you actually doing a type 1 error. And this is most of the time this error happens if you have designed the study poorly, or you have a bias somewhere. Alternatively, if there is a difference between the two treatments, and you picked up that there is no difference, then you're doing a type 2 error. And these are usually if you don't have enough sample size. So the study design was not good enough to pick up that differences. So you should be aware about these two type of errors. Then the results, in the paper, you should be reading how they have discussed the results. There should be no misinterpretation, because you might see at the table certain results, but while in discussing those results, they might have misinterpreted that. So that is again can lead to some bias, and it will be misleading. The strengths mentioned should be the true strengths, and if they have a limitation, first of all, have they discussed these limitations or not? If they have discussed limitations, these limitations are not going to affect the applicability of the study. So if you have an issue where the limitations are actually causing some generalizability issues, then probably this is not a good study. Then the conclusion drawn should be a true representative of the results and discussion stage. Now, overall structure of the paper, because we are having a lot of research, so you could have a randomized control trial, you could have a systematic reviews or case reports. So every journal has structure and the paper should be reported according to that structures. That ensures the quality of reporting the paper itself. So if you have a randomized control trial in your hand to critique, then you should see whether they have reported this according to the CONSORT guidelines, which are the consolidation statements of reporting these randomized control trials. And similarly, if it is a systematic review, have they mentioned that they have followed the PRISMA guidelines for that? And actually, the reporting of that paper is based on these guidelines. This is just a snapshot of CONSORT checklist. So it's one page of maybe 5 or 6 pages, and then you have a PRISMA checklist. Again, you won't remember everything, but if you go once through the paper, then you have an idea, have they discussed that they followed the PRISMA guidelines. Now, this is a systematic approach starting from, so there is a reality in the population, and that reality needs to be picked up. And every stage, whether you are designing a study, you are allocating subjects to the different groups, then you are actually doing the analysis, and then you are, after analysis, you are interpreting the results, and then you are doing discussion and making conclusions. So all these should be aligned with one another. So if this is done, then this is the evidence of internal validity. Now, how should we report a critical appraisal? So once you have done that, then you make a structure in your mind that you are going to present it. Now you talk about the credibility of the journal and authors, about the title itself, whether it's clear or not. Then you summarize the study within your own words, and you can talk about the abstract, whether this is structured or not, we have mentioned already, and the introduction, methodology, you critique about them, what are the good points and what are the limitations, or what are the limitations you have picked up in that study. And at the end you conclude the appraisal by saying whether this is worth following or is not of any usage. Will you apply the single paper results on the patient population into your clinical practice? Well, the answer is, one of the answers is that actually evidence-based practice does not mean that you take the evidence solely in isolation. Rather, you need to see in your clinical practice, you have enough expertise, number one, and number two, the patient agrees to that. So it's a whole system. So getting one external evidence is not actually equivalent to the application to the clinical practice. So to summarize, I would say that the critiquing research paper is an important skill. It helps in evaluation of the available research and application of the evidence-based medicine. It requires a systematic approach, and credibility is not an alternative to validity and reliability. So credible sources does not mean that the paper itself has a good structure. Even credible papers and authentic studies may not be applied to the clinical practice straight away. So that's the end of my presentation. Thank you. Any questions?
Thank you, Khalid. That was. Any questions from anyone?
Just to add that next week we'll be doing a practice on that. So I'll present one paper. I'll critique on that. Please do read that paper. It's very important.
Okay. Right. Omar?
Ali?
Hi. For today's presentation, do you want to add anything to it? Or anything?
No, I'm sorry. I'm in the ward. Sorry, C22. So I'm trying to listen. I wasn't paying full attention. I'm sorry. But thanks, Khan.
No worries. Okay.
Thank you. Rory, are you still there?
Ahmed's speaker is on. Mic is on. You want to ask any question?
Oh yeah, Norman. You always have a question. I know.
It'll be a difficult question, I can tell you.
I don't have a question. I just want to ask Khalid if he can circulate the paper that he is going to appraise the next week, so that we can read it beforehand, so that we have more knowledge what's been appraised. And
we'll definitely do it.
Helpful.
Yeah, I will definitely do it, but it has been done already by Nick Haywood, so probably. But I will redo that.
Yeah, so that we go through these things.
Sure.
Anyone else? Any questions? We got junior doctors. Ashiru, do you want to ask any questions?
We don't have any consultant around today.
We haven't actually.
Okay.
Probably they must have forgot.
No.